One of the, I guess, topics that you've put a tremendous amount of work into over your last few years, many years, has been the development of this clinical pathways to treat disease and illness. Could you
Yeah.
comment a little on what has been developed at Calgary and with some examples, maybe very relevant to what's been going on with these elective delays?
Yeah. So it's interesting because, of course, my training was in clinical basic science, and so as head of gastroenterology. So when I was acting head from 2011 to 2012. When I became head, I started to really look at the numbers. What profoundly struck me was the wait lists were massive. Like massive, thousands and
Mm,
thousands and thousands of people sitting on wait lists that realistically could never be seen.
wow.
There just was not enough manpower to see them, and so we were in this situation where so gastroenterology in Calgary gets about so there are central access and triage, which is about 22 clinical full-time equivalents of gastroenterologists to see these patients. We get about 2,000 referrals a month, and we get about another 1,600 to 2,000 or the colon cancer screening center, and another 300 hepatology referrals per month. So it's a massive number of referrals coming in,
Yeah.
and I guess to the credit of the system is we've actually been able to keep up okay, but the problem is our service had really become a service of urgent need. I mean, people that were urgent, I think we were pretty darn good at seeing them in a timely manner. I think comparable to anywhere else in Canada, and probably better than many. The problem was if you had what was just determined to be a routine problem, dyspepsia or heartburn, or maybe intermittent diarrhea, constipation, these kinds of things, which are very common in society, irritable bowel syndrome, that it was very challenging for us to see those people. In fact, they end up going onto the wait list as a routine referral, and there was no capacity really to see them, and so they just sat there. And so when I became head, people were being told that their wait time was 2 years, but of course their wait time was forever because
Wow.
urgent cases just kept coming in. And so obviously the patients were extremely unhappy. The family doctors were extremely unhappy, and the specialists were extremely unhappy. And I'm sure the government was extremely unhappy. So there was no happy people. And so just decided the only way to really deal with it was to just to sit down with the family doctors and work out a solution that everyone felt was a reasonable approach. And so we just started to do a very collaborative meeting. We met once a month for 2 hours. And we had a special retreat where we invited the government and lawyers and everyone we could possibly find. We invited, or that was willing to come, and people were willing to come. It was quite interesting, like CMPA, the College of Physicians and Surgeons of Alberta, you name it, they came, and we just talked about wait times and what it meant, and wait lists, and legal liabilities, patient issues, all that stuff. And so to make everyone comfortable that if we made a strategy to deal with it, actually it was going to be in everyone's best interest. And as long as it was patient-centric and patient-focused, then everyone could potentially win. And so we started with dyspepsia first, GERD, so gastroesophageal reflux disease, and then we went actually through all of our common routine referrals, and with sitting down at the table with the primary care physicians, we worked out these pathways. We worked out, they were all on one page as a flow thing, but we had all of this supporting document where people could go and so they could get more information. And what it allowed and it was essentially so that we could say, we can't see these patients, but if you go through this pathway and they're still having trouble, then we can see them, and we'll see them. That's our agreement with you. But there are some things that if you do in primary care, that you can actually make most of these patients will be very happy because you'll be able to deal with their problem there. And so we started to launch these pathways we started with the one with gastroesophageal reflux disease or heartburn, and then we kind of went through them all up to chronic diarrhea, chronic abdominal pain. We have a whole ton of them now, and they've been unbelievably successful. Our over a year and a half period, our wait list for routine referrals went from about almost almost 3,000, say 2,800, down to zero. And so of all the patients that ended up not coming to see a specialist, we 16% of those patients. So we did a survey of about 1,300 of them. About 16% of them end up coming back and getting a scope at some point in 2 years after they were put on the pathway. But most of them came back for something that was not related to their original referral, and they were scoped for something completely different. But also, there was no cancers found, so there was no serious pathology found in them. So we felt we had a very good, validated pathway patient, and we've done all these surveys afterwards. The family doctors love it. The specialists quite enjoy it because it's allowed them to really bond again with family doctors in a way that they'd kind of separated over the years. It was more of an animosity thing. In fact, GI for years have been ranked the worst, the least accessible subspecialty in medicine, and so we're not the worst anymore. So
congratulations on that.
That's right. Yeah. It's a high bar.
Yeah. But it sounds like it's also a case study for change management. Exactly. Where it took a sense of urgency to trigger the interest in coming together, and then you formed a guiding coalition of people to solve the problem. And I'm sure you went through that entire stepwise approach to managing change, and celebrating some quick wins and so on and so forth.
Yeah, exactly, and that's exactly, and so the family physicians in Calgary are quite well organized. They have primary care networks, they're called, and so we would go through their leadership, but also they have a very actively read newsletter and things like that. So we would let people know what successes had been achieved, what they as primary care physicians had achieved, and it was very well received because they felt like they were kind of in the loop, right? It wasn't the traditional model, which is part of the reason why specialists in primary care were having some issues in the past, where specialists would say, this is how I want it done if I'm going to see your patient. And of course, that doesn't work, right? There has to be a collaborative discussion. It has to be what works for both of us here. And so I think by feeding back how that collaboration was positively impacting their patients, and I think themselves, I think they felt because they could turn the screen with this pathway on it and show the patient, say, this is where you are. This is what we're going to do next. If that doesn't work, we're going to do this next. And if it doesn't work, then you're going to go see a gastroenterologist. I think patients really like that. They found like they were connected to the healthcare system. They weren't like in the past. It was like, okay, you have an appointment in 2 years. Yeah. Don't worry, that appointment's going to happen. Of course, it doesn't hapen, right? And so someone's waiting there in this black hole for 2 years, and no one calls. Right? It's like a bad date, right?
You've been ghosted by the healthcare system.
That's right. Yeah.
So I'm sure you're aware that there's many communities around the country that face the problem today that you were facing. How do you go about sharing? Obviously publishing is a great way to share this, but I'm sure you're having a lot of conversations with different leaders around the country on how they could also do something similar.
Yeah, many, and so obviously I'm very open with sharing whatever was successful, and because I believe this is a huge issue, and obviously you mentioned it is a huge issue all across the country. Also, we've made our pathways public, so they can be freely downloaded without restriction from specialistlink.ca, and in fact, I've had people download them from France and Germany, all over the world.
Fantastic.
And they can't believe that they can just click on it and they have it. And I said, you know what? If you want to modify it, you go and modify it. There's no patent, nothing. There's no IP, and so you just modify it to your own area, and obviously things might not work quite the same way in the different area that works here, but it's totally modifiable. And I think the broad concepts and the education stuff that goes with it for patients is applicable broadly. It's all evidence-based, validated, and so I think it allows specialists, especially obviously gastroenterologists, but this has been adopted by all the medical specialties in Calgary, and now it's being spun out provincially as well. So I think that people see the real merits in having a guide like that because there's so many referrals into specialist care as populations grow and people get older, that there's this constant feeling of that, like the zombies flowing over the top, that you just can't keep up, and you're going to get overwhelmed, and then there'll be no one left. You'll burn out, right? And I think a lot of physicians were burning out or feeling burnt out, and so this kind of, I think, gives an opportunity for physicians to not burn out, to empower them to feel that they can deal with the cases that most need their input. Like, I think if patients can be dealt with a pathway with their primary care physician, who's really who they know best, rather than going to a specialist who really might not add any value to that whole interaction, just waiting for 2 years to get told stuff that maybe the family doctor's already told them, or not offer any additional value. I think it's a better structure to have it all do as much as you can in primary care, and then if you really need help, get a specialist help, and then the specialist can actually help you, because they actually have the energy, time, all the stuff you need to do a great consult.